Hello, my name is Tyler Bonkowski. I'm an internal medicine resident from Spectrum Health in Grand Rapids, Michigan. I would like to present a unique case of primary pericardial angiosarcoma presenting as constrictive pericarditis. Primary cardiac malignancies are exceedingly rare, with an incidence of 0.02% in the United States. Of these cases, angiosarcoma is the most common and most aggressive. Presenting symptoms are nonspecific, usually involving dyspnea, chest pain, and excessive fatigue in a patient without pre-existing heart disease. Commonly, these tumors arise from the right side of the heart and will invade the cardiac wall and the pericardium, resulting in a hemorrhagic pericardial effusion. Pericardiocentesis, however, is unreliable, usually only revealing red and white blood cells without malignant appearing cells. Therefore, diagnosis usually relies on pericardial tissue samples or excised tumor. On the right is a gross pathology image from an online pathology library demonstrating a brown circumferential tumor as well as some pericardial invasion. Our patient was a 26-year-old female who initially presented to an outside hospital complaining of chest pain and orthopnea 2 days after a low-velocity motor vehicle accident. Initial workup revealed a large pericardial effusion, with subsequent pericardiocentesis revealing serosanguinous fluid without malignant appearing cells. Therefore, she was discharged with NSAIDs for presumed pericarditis. Over the following 2 months, she had persistent dyspnea that was evaluated multiple times as an outpatient without recurrence of her effusion. Her fatigue continued to progress to the point of becoming wheelchair bound over the course of about 3 weeks. At this point, she presented to our institution. On arrival, she was tachycardic and normotensive with mildly elevated cardiac biomarkers. A chest CT angiogram revealed a complex pericardial effusion. Therefore, she was admitted with a diagnosis of recurrent pericarditis. Echocardiogram showed a large, loculated pericardial effusion, which was not amenable to pericardiocentesis. She then underwent a cardiac MRI, which showed late gadolinium-enhancing fluid pockets within the pericardial space, shown in the top right image, as well as septal flattening with a D sign in the short axis view, shown in the bottom right image. This real-time MRI clip shows the patient's septal bounce and ventricular interdependence, consistent with constrictive physiology. At this point, left and right heart catheterization were performed to further evaluate her hemodynamic status. She had normal coronary arteries, however, right heart catheterization showed elevated biventricular filling pressures and cardiogenic shock with a low cardiac index. After a multidisciplinary discussion and consideration of her MRI imaging and hemodynamic data, the decision was made to pursue urgent pericardiectomy. Intraoperatively, the pericardium was easily dissected from the mass. However, there was extensive epicardial adhesions leading to bleeding and acute right ventricular systolic dysfunction, which necessitated initiation of VA ECMO and intra-aortic balloon pump. The pathology from the epicardial tissue demonstrated anastomosing vascular channels lined by atypical endothelial cells shown in the image on the top right, which stained positive for erythroblast transformation specific related gene, or ERG, shown in the image on the bottom right, both of which were consistent with angiosarcoma. Postoperatively, the patient declined with no signs of recovery with attempts at reducing mechanical circulatory support. Given her poor prognosis, she was transitioned to comfort care measures and passed away. In conclusion, this case provides several learning points. First, primary cardiac angiosarcoma is a rare disease that can present atypically as constrictive pericarditis. Diagnosis can be challenging and is often delayed due to nonspecific symptoms and typically normal pericardial fluid cytology, especially in patients with no prior cardiac disease. Lastly, cardiac MRI imaging can be useful to determine the next diagnostic and therapeutic steps in complicated pericardial effusions, especially when taken in conjunction with invasive hemodynamics. Thank you for your time.